We'll get back to you. Thank you.
Yes, old lady
Yes.
diagnosed with middle esophageal squamous cell cancer for EUS staging of esophageal cancer.
Can we have the screen to Dr. Palazzo Rome? Yes, good morning, Dr. Palazzo. Can you hear us?
Yes, you have the screen?
Yes.
Yes.
Yeah, okay, you hear me? Do you hear me?
Yes, we hear you. Yes.
Yes, we hear you.
Okay. Yes, speak louder. Okay, in the room. So we are into the esophagus of this lady. Here you see on the EUS screen, on the left part, this big black thing is the aortic arch. Okay, aortic arch. So this is the left part of the mediastinum, of the posterior mediastinum. If you look in front of the scope, so the lower part of the scope, this is the trachea. You see the air into the trachea. And when I push gently, descending here, you see I push on the beginning of the descending aorta. In front you have the azygos arch. In front of the aorta, this is the arch. Here it's still the trachea, and now the carina. The carina means that you see two bronchus, and now I push, and they are separated.
Dr. Palazzo, can someone use the cursor on the EUS to show us what are you saying? Just put the cursor. Someone put the marker on the EUS, please.
Yes, but I'm alone. So the marker here. Okay. Set. Okay. Yes. So here is the descending aorta. This is here the descending aorta. Here is the left pulmonary artery. Here is the what we call the aortopulmonary window, which is the 4A of the thoracic surgeon classification of lymph nodes. Here I move. This is the left bronchus, and you see some bubbles inside, which means that there is some fluid. And here, if I move here, this is the right bronchus, and in front, this big vessel is the right hepatic artery. Okay? So
Yes.
this is anterior, at the back is posterior, at the top, on the left is left, on the right is right. Okay, so here you have the carina, okay. Now I push gently, and we will start to the tumor. Yeah. Okay, here you see the tumor, the thickening of the wall. We are at the lesion of the subcarinal region. The lesion is posterior in front of the aorta. You see the aorta is behind. The lesion is the big thing inside the esophagus. Okay, and here at that level, it's a T2 lesion, involvement of the wall, but unfortunately, there is a stenosis which is unpassable. So when I push, you see the beginning of the left atrium below the transducer. This is the left atrium. And when I pull back, you see the subcarinal region. So it's at least a T2. And we know that when you have unpassable lesion, it's always C3, in fact. So the staging in that unpassable lesion is not for the T, because we know that it's a T3. The staging is for the lymph nodes. Of course, we do not see the lymph nodes which are below the downstream the stenosis. However, I will study the lymph nodes which are upstream the stenosis. So I'm into the esophagus here, upstream the stenosis. So you see the stenosis start at the level of the subcarinal region. Okay, here I am above the subcarinal region. I have no lymph nodes. I pull back gently, and I will study all the lymph node station. So the lymph nodes which are between the esophagus as the aorta and the trachea, we call that left intertracheal and esophageal node. And on the other side, these are the right. So I pull back, I have no lymph node, no lymph node. Now I pull back at the upper part of the mediastinum, no lymph node. And this, now I will show you here a lymph node. So if you can increase the image, can we increase the image? No, this is the gain. Yes, the depth. Increase, 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 increase. Okay. Here you see the black thing. Show the nodes if it's possible. You see this thing. Here you see it. Okay. This is the lymph node. We are posterior and right. At the top you have the spine. You see this white thing with black thing behind. This is the spine, okay? Right is on the right of the spine, left is on the left. And here you have, so this lymph node, which is there, which means that you have it's typical of metastatic lymph node. It's hypoechogenic, well demarcated, slightly heterogeneous, and it's around, I don't know, 6 millimeter, 7 millimeter, and it's far from the tumor. We are at the upper part of the posterior mediastinum, and it's typically positive. And if we do a biopsy, it will be positive.
Dr.
So
Palazzo.
the staging in that lady is T3.
Yeah, Dr. Palazzo,
Yes.
we have a question.
Yes.
So what was the stage of the tumor when we saw it earlier? Do you think it was to the muscularis propria like T3 or just T2?
Can you show us
back
the
to
four
the
layers?
tumor.
T3,
Just
since
show us
we
the
have
four
unpassable
layers from
tumor,
where it start
you
and
see
it went in.
T2,
What is the size?
You do not see the T3 part, but the T3 part is below the stenosis, at the level of the stenosis. But all the published series on this case, this kind of case, demonstrate that at the moment where they have no neoadjuvant therapy, it was only surgery. So we have the comparison with EUS and surgery without neoadjuvant, and it was always T3. So when you have a stenosis, always T3. Push an upper GI endoscope before doing EUS, and the stenosis is unpassable. I will show you, if you want, the endoscopic view. Do you want to see the endoscopic view?
So what Dr. Palazzo is saying, it was to
Yes.
the muscularis propria, so it's T3. And whenever you have lymph
Speak
nodes,
louder.
it's beyond endoscopic resection. So yeah, we were just talking about the staging. So you mentioned it was T3 with the presence of paraesophageal lymph node. Is that right?
Yes. T3 and 1, yes.
Yeah.
T3 and 1, but the important thing is that the nodes is at the upper part. So for the radiotherapy, they have also to put the upper part of the mediastinum into the field of the radiotherapy, and not the mid and the lower part, but also the upper part.
Good. So I think one of the main things we do in staging is to see, I think the only difference if it is T1 or not. Once it's T2, 3, 4, or lymph nodes, I think they're all going to chemo radiation. The only thing is T1 that can go to endoscopic resection.
I
or
agree.
PSD.
I agree. I agree. But the fields of the radiation is sometimes useful also. For example, you have a cancer of the upper esophagus, and the lymph node, the metastatic lymph node is at the level of the celiac area, and it's a 7 millimeter, proved by biopsy, but not seen on a PET scan, CT scan, what you want. What do? You do chemoradiation on the mediastinum, and you forget to put some radiation also on the celiac region, and you cure the lesion at the level of the mediastinum, and because the chemotherapy is effective, the node disappears, and when you come back 1 year later or 2 years later, the recurrence is at the level of the celiac axis, where was the first node. And at that moment, you put radiotherapy and chemotherapy on the celiac region. If you know before beginning the treatment that the field of radiotherapy has to be bigger than expected because of the location of the tumor, you are better for the people. So the staging, it's a two-way to see the staging. You want to be optimal or you accept to be suboptimal. If you accept to be suboptimal, you do upper GI endoscopy, CT scan, PET scan, that's it. And you will be perfect in 90% of the cases. And in 10% of the cases, we will not be perfect. So your patient will not be optimal treated, optimal management. It's like this. You want to be optimal or you accept to be suboptimal in 10% of the cases. This is medicine. This is medicine.
Great. Well, thank you very much, Dr. Palazzo. Is there any question or comment?
Suppose
Can I
it is
show you
palliation and I want to put the stent.
Endoscopy view.
How long is the so how long you put the stent? It is in the mid-esophagus, subcarinal. So if I decide to put the stent as palliation, advanced.
No, you see, this is the food. This is food, and the lesion starts at immediately above the carina, here. The lesion starts here, immediately above the carina, and this is an unpassable lesion. I have started with the upper GI endoscope. I have started with the EUS scope, of course, and it's unpassable. So you have the upper part and the low and the big and the first part of the mid part of the esophagus. Here you see we are at the Killian mouse. Okay. Okay.
All right. Well, thank you very much, Dr. Palazzo. We'll